want to talk to you about how we implement this learning in the consultation and how we can improve the quality of asthma care in our practices and really link this in with the new Medicines Management Enhanced Service. So I wanted to start with a case study because that can often help us bring this all together in terms of thinking, what would we do with a patient we saw? And I'm going to talk to you about a patient I saw a few years ago. And this was a female patient in her 30s who'd had a diagnosis of asthma since childhood. She actually came in to see me with a skin complaint, but then mentioned at the end of the consultation that she'd been coughing through the night for the last 2 months. And the concern for her was that it was keeping her and her husband awake. When I asked her what helped her with the cough, she said, well, she used her blue reliever inhaler and she was needing it most days. And then she sort of talked about the fact that her symptoms tended to recur in the winter, but in the summer she was fine. She was completely symptom free. When I asked her how was she taking her preventer inhaler? Did she sometimes forget? She said, well, I often forget to use my inhaler. When I do use it, I tend to use it once a day. She was on a metered dose inhaler and she wasn't using a spacer device. So I looked through her notes and we found that she was on a very low, almost pediatric dose of ICS inhaler. And I think this was because she had expressed concern about the side effects of inhaled corticosteroids and perhaps those weren't addressed. Also, her birthday was in the summer, so she was having her asthma reviews in her birthday month. And in the summer, over the last 4 weeks, the ACT score was always excellent. And that's why her treatment had never been stepped up. But actually, when I looked at her objective data, that showed that she was overusing her reliever and underusing her preventer inhaler. And this is extremely common. So I asked her, show me how you use your inhalers. And she showed me that she was taking a quick and fast breath with her metered dose inhaler, which is not appropriate for that type of inhaler. And we had a conversation. So we talked about how asthma is an inflammatory condition. I tried to raise her ambitions of what good control should look like. We discussed whether we should increase her inhaled corticosteroid dose or maybe move to a combination ICS formoterol regime, because that might be more convenient, it might be simpler for her. And I offered her a dry powdered inhaler because it was suitable for her technique. It had a dose counter and it didn't require a spacer, which she wasn't using anyway. And then I followed her up at 6 weeks. Now, it's obviously really, really important that if we do any changes in either medication regime or inhaler devices, that we have a system to follow our patients up. And when I saw her at 6 weeks, she had a complete transformation. She wasn't coughing at night anymore. And more importantly for her, she had been limiting her activity because she was getting symptoms. So she would say her asthma was good, but actually she wasn't exercising because it brought on her symptoms, and she'd started to go to the gym and she'd lost weight, which she was very happy about. Her peak flow, an objective test, had improved by 20%, and she hadn't needed to use any of her extra reliever breaths at all in her MART regime. Okay, so that's about putting it together in the consultation. What about quality improvement opportunities for asthma care? And it's not just in the consultation. So we have opportunities at system level as well as at our encounters with our patients. You know, it might be when the patient first presents to the symptom and are we coding that they have suspected asthma. It might be when the patient's requesting medication, and that might be reception involvement or practice pharmacy involvement. It might be during medication review. It might be an annual asthma review, or it might be when they attend some sort of emergency setting and then we get the letter back. And what are we doing with those letters and how are we reviewing our patients? So plenty of opportunities for us to do quality improvement. And we've tried to reflect those opportunities in the implementation pack that we've put together with the Medicines Management Enhanced Service scheme. So I'm just going to talk you through this scheme and what the 3 areas are. So the first one is looking, how can we identify and prevent poor control? Now, you may be familiar with this indicator because it used to be in the impact and incentive scheme. So we're asking you, each practice is required to ensure that the percentage of cough asthma registered patients who receive 6 or more SABA inhaler prescriptions over the previous 12-month period, we're asking you to reduce that number. Now, the target range, I think, is 15 to 25%, the lower the better, basically. But we are asking you to look at the target range for your place. Now, you might say, why 6 or more? Why not 3 or more? You've just shown us evidence that outcomes are worse if you're needing 3 or more. The reason is purely pragmatic. SABA overuse is such a big problem in our asthma population, and there are patients who are on far more than 6, that this is just targeting the worst control population. But you may choose to look at 3 or more, but this is what the incentive scheme is based on. So the first one is identifying and preventing poor control. The second is looking to see getting the right treatment, the treatment to the right place in the airways. I probably shouldn't put small airways, I should probably put airways there. So each practice is required to ensure that the number of pressurized metered dose inhaler prescriptions as a percentage of all non-salbutamol prescriptions, basically your preventer inhalers, issued to patients 12 years and older, because we're recognizing that children who are under the age of 12 may not be appropriate for a dry powdered inhaler. So it's looking to make sure that we're appropriately considering dry powdered inhalers in patients who are 12 and over with asthma. And again, no bulk switching here. This is as we see our patients. It's a shared decision-making process. And again, here, the lower the better. That your target will be different for your place depending on whether your place is starting at a high level or a low level, but the lower the better. And then the third indicator is actually nothing to do with quality at all. This is just a cost effectiveness measure. And so this is to improve the cost efficiency of asthma prescribing. We're asking that where you're prescribing ICS LABA combination inhalers, that you consider choosing lower cost products. So for the dry powder low carbon inhaler, that's Fobumix. And if a person needs to use a metered dose inhaler, we're suggesting Lufabac. So obviously, we're still wanting you to move towards lower carbon inhalers, but this is really because the different inhalers have different costs, and these are the 2 of the cheaper ICS for multiple combination inhalers. I just want to point out that Lufabac has been marketing itself as a carbon neutral inhaler. Please don't be taken in by that. That's to do with carbon offsetting. It is still considered a high carbon metered dose inhaler, but it is a cheaper inhaler if somebody does need a metered dose inhaler. The thing to be aware of with this Medicines Management Enhanced Service Scheme is that in order to get the payment, you have to have hit at least the lower threshold of each one of these indicators, because what we didn't want is for people to just do the cost effectiveness and not do the quality indicator scheme. So the 2 top ones around identifying and preventing poor control, making sure the person's on the most appropriate inhaler, those 2 have to be achieved to some extent. All 3 have to be achieved to some extent in order to get the payment. Okay, so how are you going to actually do this? So you should have all received an implementation pack. And in that pack, what we've tried to do is make it really quite off the shelf for you to do the quality improvement work in order to achieve these incentives. So the first thing is to actually do the search, and the search should have been sent to you about just being able to identify all of those patients who are on the QOF asthma register who are on 6 or more SABA inhalers. And then you need a process for reviewing those patients. Are you going to try and review them all at the beginning of the year, or are you going to do them according to birthday month? That's a discussion you need to have in your practice. But there are simple system changes that you can make as well. So for instance, you could choose to take SABA off repeat. And Dr. Tim Ryder has done this in his practice. He did this a few years ago and has developed a video about how to do this safely, and we put that in your implementation pack. So if you do want to consider taking SABA off repeat completely and making sure that people, when they come to see you, have, say, 2 SABA initially, and then if they're requesting more, you have a safe process for making sure they do get the inhaler they need but are reviewed, you could look at that. Or you could change your prescribing interval. So you could look at least 90 days, so people can't get more than 5, and putting a maximum issues of 5, and that will stop people automatically getting more than they should of the short-acting beta-agonist inhaler. Again, you could choose to make that 180 days and a max issue of 2 if you wanted to as well. The other thing that you can do simply is you can add Accurix messages to your practice templates on SABA overuse and asthma control, and you can bulk send these to all of your asthma patients, or you can incorporate them into your asthma review and invite. So, or you could just give it to the patients who are identified by your search. And I'll show you some of those in a minute, but there are literally practice template Accurix messages that we have written for you. You can change them, or you can just cut and paste them into your existing system. And then I showed you the visual guide. You might want to print these out or put them on your desktop to help you with your asthma reviews. So just a reminder, in your implementation pack, you'll have an appendix at the end, and it's examples of Accurix messages that you might want to use, and they have automatic links to videos and leaflets as well. Again, they're just example videos and leaflets. There are others that are available, and if you go onto the Green Practice Toolkit, it gives you other examples that you might want to have a look at. So for instance, they say things like, if you need to use 3 or more rescue blue inhalers a year, this more than doubles your risk of an asthma attack. To ensure we identify patients whose asthma control needs improvement, our systems will no longer allow patients to receive more than 5 a year without a check from a healthcare professional. Now, that's if you choose to change your prescribing intervals. Obviously, you'll need to change that message if you take it off repeat. But you could also send people a bulk message about good asthma control means you will rarely or never have symptoms. Many people don't realise their asthma could be better controlled. It's important to take a preventer inhaler regularly, even when you feel well. If you need 3 or more rescue blue inhalers a year, your asthma control may need improvement. To learn more, watch this video, read this leaflet. So we have tried to make it as simple as possible. Getting treatment to your airways. What are the system changes you could do? So I would recommend that people have the HMY asthma guidance on their desktop or printed in their room. It's got lovely images, and then you can quickly refer to what it is that you should be prescribing. I mentioned before, you can get placebo packs of the different dry powdered inhalers. You should also perhaps consider getting those inhaler training devices to help you decide with your patient which is the best inhaler with them. We talked about changing asthma invite messages. So if you are going to change an inhaler device, then you probably ought to be sending people a little video link through an Accurix template message to say, I have prescribed you a Nexthaler or a Turbohaler or whatever inhaler to reinforce that. And we put those in the implementation pack as well. But if you're the only person today here at this training session from your practice, it's going to be difficult to actually change unless you've all as a team understood the transformation in asthma prescribing that's happening with combination inhalers, and how we can use dry powdered inhalers effectively, how we choose them. So it is going to be really important to run a session in your practice around learning, working out what system you're going to use to make sure that the patient's inhaler technique is observed during asthma reviews. That is a crucial point. We have to be checking people's asthma inhaler technique if we're going to make the right decision about improving their asthma inhaler technique and maybe potentially changing their inhaler device. Another thing just to mention is that the new medicine service that community pharmacy have mean that if you prescribe a new inhaler device, they will reinforce that when they dispense that new inhaler device, and that you can encourage that by the first time you're prescribing a new inhaler, put 4 NMS inhaler technique on the script note. So you don't want to have that on every single time you prescribe a dry powdered inhaler if a person's well on it, but the first time add that onto your script note. And then you need a process for reviewing patients at around 6 weeks after their inhaler device is changed. So this is just to let you know that there is a web page which has got all the guidance on it, and it's also got links which you can use for education. So there's the Sentinel Quality Improvement Framework, there's the Humber and North Yorkshire Healthier Together website that Jennifer mentioned, there's the Greener Practice Toolkit, which has got resources around quality improvement implementation, and then there's really fabulous patient-facing resources from Asthma and Lung UK.